Welcome everyone to the 13th meeting of our 2021 virtual Fabry Community meeting series. Thank you for being here, and we'll hope that some other folks show up that have registered before we get into tonight's talk. Thank you to Dr. Jaya Ganesh from Mount Sinai for being with us tonight to give a talk on chaperone therapy. And as always, thank you to my co-host, Dawn Laney, for being here and keeping me out of trouble and handling the questions and answers that I sometimes don't hear as well. So I'm going to tell you a little bit about Dawn. Probably, maybe I can come up with something you don't already know, but I'll tell you what I know. So Dawn is from Emory University. As many of you know, Dawn is, let me get this closer to me so I get it. I know very well what Dawn does every day, but I have to have some help in getting it right, the official version. So of course, Dawn is a genetic counselor. She has a master's degree and is a certified genetic counselor. She's an assistant professor, a clinical researcher, program leader of the Lysosomal Storage Disease Center, and director of the Genetic Clinical Trial Center in the Department of Human Genetics at Emory University in Atlanta, Georgia. So Dawn has lots of notches in her belt. Her clinical and research interest has been focused on Fabry disease for many, many years. So she's one of our experts in Fabry disease that we rely on so much. And she is also the co-founder of Think Genetic, which empowers patients who want to know more about possible genetic causes of their medical issues. And you can read more about that in her bio. And Dawn likes to write children's books. And if you've been on our website and look down to the bottom in one of the lower sections, you'll see some of the books that Dawn has written about Fabry disease. And so she does a great deal of things for our community. And we're going to let Dawn formally introduce Dr. Jaya Ganesh. Thank you, Dawn.
Thanks, Jerry. It's always nice to hear the introduction from you. So I am very excited to introduce you to Dr. Jaya Ganesh. She is the Assistant Professor of Genetics and Genomics and Pediatrics at Mount Sinai. And we actually got to spend more quality time together recently, not just because we share this highway of patients from New York to Atlanta, but we also have got a lot of time thinking about COVID disease and the impact of COVID disease in Fabry patients. And that's where we got to spend a lot more time, and I got to know how she thinks in a very analytical but caring way. And I think that she is the perfect person to talk to us about Galafold from her unique perspective, in which she works with many, many Fabry patients across all walks of life, and has also more recently, gone through what it means to have patients who have COVID or at risk for COVID, and how that's all come together. So with that, I will turn it over to you.
Thank you, everyone. At the outset, I have to, I'm reading this CC chat, and I hear from two people with very good accents, and the chat is still making some very funny mistakes. Now, my accent traveled a long way from India and, a little bit in the UK, and then all the way to Philadelphia and then to New York. So I don't know where it is from anymore. So if there is something that does not make sense, I request Dawn to, correct it, because if I'm saying something really weird or sounds very weird, my apologies. And please feel free to stop me. I don't have a very packed presentation, so there will be a lot of time for questions. So all that said, I'm going to try and share screen. There it is. And can everyone see my screen now? Yes.
It looks great.
Excellent. So today I'm going to try and talk to you about pharmacologic chaperone therapy for Fabry disease. And As part of my work at Mount Sinai, I do receive research support from various industry partners, and I also serve on the advisory boards of some of these companies, particularly in the field of lysosomal storage diseases. But these relationships are not relevant to my talk today, and all the information and data that I've presented here are available in the medical literature, compendia, and public domain. No investigational work is being presented. So Fabry disease, I don't have to introduce it to this audience, but just to review, it is an X-linked lysosomal storage disorder due to the deficiency of the enzyme alpha-galactosidase A, or alpha-GALA or GLA. And because of the enzyme deficiency, there is accumulation of substrates, globosyl ceramide and the hydrolytic form, the lyso-Gb3, in tissues and various organs. And as a result, there is organ damage and premature death and organ dysfunction with renal failure, strokes, and hypertrophic cardiomyopathy are some of the cardinal changes that you see in a patient untreated with Fabry disease. And even though it is an X-linked disorder, we very well know that female patients also suffer from Fabry disease, and the severity in any given female depends on the degree of X inactivation. And despite a female patient having a high GLA activity in the plasma, that should not translate into, oh, she does not have symptoms of Fabry disease, because every tissue, the level of X inactivation can be variable, and females are also prone to developing the organ damage that is characteristic of Fabry. And biweekly enzyme replacement therapy. So if the patient is missing the enzyme, we replace the enzyme with infusions, and that's the standard of care for most patients, and it slows the disease progression significantly, and we have very good data to indicate that. However, enzyme replacement is not a cure, and treatment also includes a reduction of cardiovascular risk factors and management of these symptoms. And the problem with enzyme replacement therapy is it may not be effective in some patients due to poor organ incorporation and taking up in the sites where it needs to work, and lack of cross-correction, meaning the uptake into the lysosome. And another big problem with ERT is that a significant number of patients, particularly the most vulnerable ones with the most severe forms of Fabry disease presenting early on in life, the classic type 1 disease, develop antibodies to the enzyme replacement therapy, up to 40% in some literature. And when you develop antibodies to a protein that is being infused, obviously its efficacy is going to be decreased. And this is a slide that I borrowed from one of the company's slide decks. So this is enzyme replacement therapy, which is given every 2 weeks. And so here is the first infusion. There's a nice peak of the GALA from alpha GALA from the enzyme. But then the half-life, the duration that the enzyme lasts in the body is very small, a few hours at most. And then after that big spike, the enzyme goes back down to very low basal levels. And then for the next 2 weeks, there is not going to be much enzyme that the various tissues in this body are exposed to until the next infusion comes along and you have. So you have these spikes and troughs, and this is not the normal exposure of tissue to a good functioning enzyme. So these spikes are probably not that helpful, and the troughs are times when the patient is not really seeing the treatment. So, Don, I think you're chuckling, but I am going to go ahead and do a little bit of a genetics tutorial for the Fabry community. So, chromosomes, the DNA, and the genetic code. And it's important to understand this because that is probably the best way we can discuss how the chaperone works and why it works in some people and why it doesn't work in others. So here are the chromosomes, the 46 of them arranged in pairs, and the last are the sex chromosomes. And in a male, you have one X and a Y chromosome, and in a female, you will have the Y is not there, you'll have two X chromosomes. And the Fabry gene is on the X chromosome, it's coded on the X chromosome. And when you think about a chromosome, this is a chromosome, structure of chromosome. And if you unravel this chromosome methodically and painstakingly, and you unravel it and unravel it and unravel it, essentially it is a piece of DNA. This is the iconic double-stranded DNA structure. And if you unravel it even further, these are the nucleotides or the base pairs that carry the genetic code. And you have 4 bases, A for adenine, T for thymine, G for guanine, and C for cytosine. And the entire code is written in with using these 4 base pairs in a particular order, which appears to be random, but it's actually a very important sequence. And 99.9% of human beings share the genetic sequence. That small difference of 0.1% is what underscores the diversity from one human to another. And the other important thing to remember is these base pairs tend to pair with each other. So adenine always pairs with thymine, and guanine always pairs with cytosine, and vice versa. And so here's your DNA, and a segment of the DNA is a gene. And here is the code: thymine, adenine, cytosine, adenine, etc. And this is the segment of DNA that's going to be transcribed. And the second important molecule, the RNA machinery, comes into play, and it faithfully reproduces the code. So T will be transcribed as an A on the RNA. The adenine will be transcribed. RNA does not contain thymine, instead it contains uracil. So A to U, C to G, and so on and so forth. And another important thing to remember is these base pairs, 3 of them together are called a codon. And so these triplet codons, each one will code for a particular amino acid. So the sequence AUG codes for an amino acid methionine. GUG will code for another amino acid valine, and so on. And so from the DNA, the mRNA transcribes the code and then translates it into proteins. And as these amino acids are forming as beads lengthening a string, ultimately these condense to form the mature protein structure. And that's what I show here. So this is the gene. The gene has parts called exons, which are coded, and then intervening segments called introns. And the RNA transcribes it, and then gets rid of all the introns, and only the exons are behind. And then the translation happens, and here you have an amino acid chain. And this amino acid chain is modified further, trimmed, pruned, packaged, etc., and ultimately to form your protein structure. So this protein could be anything. It could be the keratin in your hair. It could be melanin. It could be the Fabry enzyme. It could be another enzyme. It could be hemoglobin. So any of these proteins, this is the way they are made. So what happens? How do these mutations happen? How do we get disease? So when you think about diseases, you can think about 2 classes of mutations. A mutation is a change in the code. So here is at the DNA level. Here is a no mutation. This is the normal code. And at a codon, it was T, T, and C. And at the mRNA level, T gets A, and G, and that codes for the amino acid lysine. But if the last C in the codon was switched to a T, and so now you get a TTT, and that transcribed as AAA at the RNA level, now that codes for an amino acid lysine 2. So no change. So such a mutation is called a silent mutation. If, on the other hand, the first T was replaced with an adenine at the DNA level, at the RNA level, it becomes a U, and now the UAG tells the gene, okay, enough, stop coding, no more picking up any more amino acids, let's stop the protein, no more synthesis. So that's a stop codon. Similarly, a C becomes a G, that codes for an amino acid arginine. So you started out with a lysine, and now you ended up with an arginine. If a G is inserted here, you started out with a lysine and you become a threonine. So these are missense mutations. So instead of having the original amino acid in the protein sequence, you're replacing it with other different amino acids. And these can be missense, or it could be a stop, or it could be a silent mutation. So as opposed to other mutations that insert and delete the nucleotide base pairs. So instead of simply substituting, say for example, a CCT is the normal code, in some mutations, missense mutations may substitute a G instead of a C, and you get an arginine. But instead, if you have an insertion of a G, so instead of CCT, you actually inserted a G between the two C's, you get a CGC, and you get an extra A at the end. And now the codon changes from a TAT, CAT, CCT, AAG to TAT, CAT, CGC, TAA, and so on. So the reading frame of these of the DNA code is completely altered. And the same thing happens if you delete a letter, a base pair over here, and again, the reading frame is completely altered. So a simple example is a fat cat ate the rat. Recognize that all three are three-letter words, a codon. But if you change the fat to a hat, the hat cat ate the rat. Doesn't make sense, but at least there is some, you can get by. Whereas here, if you start deleting letters and inserting letters, then the sentence makes no sense at all. And these are called frame shift mutations. So the insertions and deletions are frame shift mutations, and they effectively destroy the gene. And so protein, and you cannot really make sensible protein. Now, why am I discussing this? Because most of the patients who have these kind of mutations, frame shift mutations, insertions, deletions, etc., are really not amenable to migalastat. So the majority of the patients who are amenable to migalastat are patients who have missense mutations. So you have a mutation, and this is the mature protein, and the mature protein has to bind to the substrate to destroy it. So the mature protein basically digests the substrate. And these proteins have various, the structure is very elegant and very unique, and each protein has its own mature tertiary structure. And here you have a protein where there is a nice pocket for the substrate to bind to. And this is called the active site of the enzyme, which binds to the substrate. And if there are no mutations, depending on the charge, the protein structure, and the chemical changes that are associated with this, the substrate binds nicely and the protein can degrade the substrate. If, on the other hand, you have a mutation, so for example, where there should have been a lysine, you now have an arginine, a missense mutation, or something else happened, then the charge, the protein structure, the conformation, everything changes. Substrate does no longer binds to the enzyme, and you have a disconnect here, and the enzyme is inefficient. So these are some of the ways where diseases happen. And this is one of the very important slides. It's a slightly older paper where we started understanding about these molecular chaperones. So focus for a minute on the left-hand side, part of the slide. So this is the normal alpha-galactosidase A, the Fabry enzyme. So it's coming along from the nucleus, the DNA, RNA, and now the protein is being formed. And this is what we call the nascent protein, just as it is being made. And the nascent protein needs to go all the way from the endoplasmic reticulum, which is part of the cell, all the way to the lysosome, where the substrate is waiting for the protein to act on. So in this long, perilous journey, a lot of changes happen. This protein needs to be folded and modified and assembled correctly. And there are within the body molecular chaperones, which chaperone this protein. They literally take it across and help it out to get to the lysosome. And if the protein is normally formed with no mutation, the molecular chaperone will help it to fold and then separate away. And then the mature protein goes into the Golgi apparatus, etc., and then goes into the lysosome. The pH of the lysosome is pretty acidic, and that's where its substrate is waiting. And in that acidic pH, it binds to the substrate and degrades. Outside the lysosome, the pH is not acidic, and the enzyme is not very functional, and that is why you don't have the degradation of the substrate outside the lysosome, whereas in the acidic pH of the lysosome, it binds and it degrades. So to the right here now, you have a mutant alpha-galactosidase A. Something happened, something changed. Now the molecular chaperones are coming along and trying to fold it, but no luck. It's not folding, it is not proper. And then the body sees this piece of amino acid string lying there, not looking right, and promptly degrades it. It doesn't want it to accumulate. So sometimes there's some degradation, sometimes these broken pieces, mutant pieces of protein may aggregate and in themselves may do more harm than good. But this is what happens when the protein structure is not conducive to these molecular chaperones chaperoning. So now you introduce a chemical chaperone. And the chemical chaperone now binds to this mutant protein and somehow alters its configuration. And now it looks more and more like what a mature protein, normal protein would look like. And then it is able to get by and come into the lysosome. And here it's able to bind to the substrate. Now, the other important thing about this is the substrate has, if the chemical chaperone stays bound to this mutant protein, then the substrate can no longer bind. So within the lysosome, there is a lot of substrate which has a very high affinity for the enzyme, and there is competitive inhibition, competitive release of the chemical chaperone. And now you have the enzyme binding to its natural substrate and degradation can occur. So this release of the chemical chaperone is also very important. If it stays bound, then it's not going to function because it's not going to pick up its natural substrate. So that is why designing a substrate and designing the chaperone is extremely important. So how do you decide whether a particular mutation in a patient with Fabry disease is amenable or not amenable to this chemical chaperone migalastat? So these were some very nice experiments that they did, and I'll simplify this for you. So some terminology, GLA wild type, WT means normal GLA, no mutation. Mute means there is a mutation. So what you do is you take wild type and you take the mutant and you incubate it with migalastat, which is deoxygalactoneuromycin migalastat. And so you'd incubate half of them with the migalastat and the other half you incubate without any migalastat. And then you break them down, you lyse them. And then you measure the alpha-gal A activity, the enzyme activity in these cells. And here you are on the y-axis is the percentage of alpha-gal activity, percentage of wild type, percentage of normal, and then the various subgroups. So the blank bar, the white bar is wild type without any chaperone. So a normal individual with no migalastat. The second bar, the black bar, is a normal individual with no mutation. But if you incubate even a normal individual with migalastat, you are able to show that the alpha-gal activity goes up a few percentage points, and it's pretty significant. The p-value is less than 0.05, so it's 0.001. So pretty significant increase, even in a normal individual without any mutation. And then here is a patient who has a Fabry mutation, but you did not expose this to migalastat. And look how low the enzyme activity is compared to the normal. And here is a green bar indicates a mutant cell line with a Fabry mutation that was incubated with migalastat. And you can see that the level of activity increases a few percentage points. And if you see how significant this increase was, the P is less than 0.01. So it is a significant increase. So by each and every mutation that is on the Fabry gene goes through this process, and they are able to assess whether it's amenable or not amenable. And how do they call it amenable or not? Mutations are defined as amenable when, in the presence of migalastat, the activity of the enzyme increases more than 1.2-fold over baseline. And if overall there is an absolute increase of the enzyme activity to more than 3% of the wild type activity. So take, for example, a patient who has a Fabry alpha gal activity of, say, 2, and you exposed it to migalastat, and you did this experiment, and if his activity went up to 3, then that is a non-amenable mutation because it does not meet criteria. Whereas, so that is how these mutations are scored, and they probably have this assay tuned to a degree that, you know, just by looking at the mutation and looking at the structure and where the mutation exactly is, some of these are probably, there is an algorithm, I suppose, in actually doing these. So this is how the company, the manufacturer, puts out a table of migalastat amenable and migalastat non-amenable mutation. And the reason I went through some of the basic genetics is that majority of the patients who have mutations that are missense, about a third of them are amenable to migalastat. 40% of missense mutations are still not amenable to migalastat. And some of the frame shift and the insertions, the deletions, and the stop codons are not amenable to migalastat. So take, for example, you have a patient here who has an activity of 1, and you expose it to migalastat, and the enzyme activity level goes up to, say, 3. So now that's a 3-fold increase over baseline. But if you compare it to the wild type, as a percentage of the wild type, it is a very small number. So you cannot say that that person is very efficiently going to respond to migalastat. So as a physician, when we look at these mutations, we are not looking at these absolute increases with the migalastat based on the data, but we are also looking to see what percentage of activity as a percentage of the wild type did that migalastat confer on this particular mutation when the patient had, when the cell was mutant was exposed to about 10 millimoles of migalastat. So that is how this is done. And here is another cartoon that says this is the enzyme, the Fabry enzyme, nicely folded with a nice pocket for the substrate to bind. And here is a mutant protein, which is misfolded, not quite looking the same as this one. And here is one that it looks even worse, where it is even more misfolded. So this is intermediate. This is completely misfolded. And if you introduce a pharmacological chaperone, migalastat, and now this enables this intermediate misfolded enzyme to fold better and enter into lysosomes for normal function. Whereas if it is so destroyed because of the severity of the mutation and even the site of the mutation, then this misfolded protein will ultimately be degraded and is not responsive to migalastat. So here is a cartoon of the Fabry gene, and this is a very old slide from Dr. Pastorius from 2002, but I thought this was a nice illustration of the gene. The dark bands up top here are the exons, so there are about 7 exons in the Fabry gene, and the intervening blank bars are the introns. And the list below each exon lists the mutations in each of these exons as it was known in 2002. So these are set of mutations are in exon 1, these are exon 2 mutations, exon 3, exon 4, and so on. And this particular mutation, N215S in exon 5, is probably one of the most amenable mutations to migalastat. It is a late onset mutation. People with N215S escape the classic features of the early onset Fabry disease like acroparesthesia, the angiokeratomas, cornea verticillata, etc. But they may present with a cardiac phenotype with hypertrophic cardiomyopathy. And increasingly, we are finding this mutation come through in our clinics when cardiologists send a genetic panel for people who present with cardiomyopathy. And we're also seeing this in prenatal couples who undergo prenatal screening. And one of them, the female or the male even, has the N215S. Very amenable to migalastat, and we have a few patients on this. And the thing about this is, so many of my patients with N215S, when I look at the Fabry biomarkers, I can barely detect any of those lyso-GL3 or the urine GL3 in their urine, but they have cardiomyopathy. They do have disease burden. So it's very difficult to track how they are clinically responding to this. So this is N215S. So at position 215 in the protein, an asparagine changed to an amino acid serine. It's a missense mutation. Go down to R220X. So this is 215. This is 5 places over the other way. And arginine, there was a missense mutation, and now X indicates a stop codon. My guess is this R220X is not going to be a migalastat amenable mutation. It's probably going to be associated with a much more severe phenotype. So yes, they are both in exon 5, pretty close to each other, but there may be big variations. And so that is why each mutation has to be looked at on its own merit. And the amenability table will tell you whether it's amenable or not. And you can Google it if you do Galafold amenability table. And if you know your mutation, you can plug it in and see. And today, so this is data from 2002. Right now, more than 1,000 mutations are known in the Fabry gene. Some of those are variants of uncertain significance. We don't know if they're really associated with disease or not. And every time I encounter a new mutation, I write to the company and I ask them to run the assay depending, and then they tell me whether that mutation is amenable or not. And once we know and once we identify that this is a known pathogenic mutation, then it gets plugged into the databases so that the next time around when somebody is looking at it, they understand that it is an amenable or not amenable mutation. So pharmacological chaperone therapy for Fabry disease. I'm going to stop here and see if there are any questions so far as to how this drug works and what the mechanisms are of function.
So I got one question submitted just to me, and it was, why is this dosed every other day?
It's following. So it is dosed every other day. Maybe I'll go back to it while we are thinking about it. It is dosed every other day because for various reasons. But one common thing to think about, and that's how I think about it, is if you introduce this chemical chaperone and it stayed tied, and plenty of chemical chaperone around, and it stayed tied to the enzyme. So when the enzyme went into the lysosome, there is so much of chemical chaperone tied to the enzyme that it competitively inhibits the substrate from really binding to the natural substrate that it's supposed to destroy and degrade. So that is why every other day dosing helps in maintaining the level of molding and folding of the enzyme. But once it reaches the lysosome where its native substrate is available, the levels are sufficiently low that there is competitive disinhibition. The chaperone gets thrown out and it binds to the natural substrate. So that's one way, one of the reasons why it's dosed every other day.
Sounds great, thank you. And then is anyone with classic Fabry disease, do they have amenable mutations?
Absolutely, yes. So that's another good point. So it all depends on the structure and the way it binds and way it folds the enzyme. So patients with classical Fabry disease are known to have amenable mutations.
Great, that's all I have right now. If anybody else has any other questions.
And the reverse is also true. Patients with the late onset cardiac forms or just the renal form or the variant forms of Fabry disease may not have a migalastat amenable mutation. There are certain ethnic predispositions to mutations because of a founder effect. There is a Taiwanese mutation, as we like to call it, which actually affects the changes the reading frame, and that is associated with late onset Fabry disease, and that is unfortunately not amenable to migalastat. So that whole population of patients are unable to benefit from this drug.
Great. One question here, has evidence been published to validate a man? Oh, well, that's the same question. Never mind. I'm repeating myself. All right, thank you so much.
And the chaperone doesn't choose between genders, male, female, they respond.
Good point.
Thank you so much, Dr. Ganesh. And what we'll do if there are no more questions.
I think she has another part, Jerry. That was just her in-between pause.
Oh, okay.
So it's migalastat is a first-in-class small molecule pharmacological chaperone. It binds and stabilizes to amenable mutant forms of the alpha-gal A enzyme in the endoplasmic reticulum and facilitates trafficking of the mutated enzyme to the lysosome. And the dissociation of migalastat and the lysosome is important so that the alpha-gal enzyme is now released and free to pick up its natural substrate and degrade. So this is the natural substrate. This is the globotriacyl ceramide that accumulates in Fabry disease. And this is the binding site for the alpha-gal A enzyme. And this is the structure of the pharmacological chaperone. And look at the similarity in structure. And that is what enables it to bind to the alpha-gal A. But when it is, the natural substrate is in abundance, this comes off and this binds to the enzyme and gets degraded. So here are a few slides. So this is a paper that came out in the New England Journal of Medicine in 2016. And this was just before migalastat was FDA approved in the United States. And it looks at the treatment of Fabry disease with the chaperone. And what they found, and this is a European study, and what they found was they compared migalastat versus placebo. And the experiment was constructed in such a way that patients initially were randomized as to migalastat and placebo. And then the migalastat group continued migalastat. The placebo group was switched on to migalastat, and then there was an open label extension and so on. So there is the FACET study and the ATTRACT study, and there's a lot in the literature. But essentially, these were the conclusions. They found that compared to placebo, migalastat decreased the GL3, the inclusions, the storage inclusions in the kidney interstitial capillaries, in the blood vessels, small blood vessels of the kidney. It decreased the storage in the glomerular podocytes, which are cells of the kidney. It lowered the plasma lyso-Gb3 level in the bloodstream, and that was with 6 months of placebo, so that it was pretty significant. And in those patients who switched from placebo to migalastat at 6 months, even they saw a decrease in the lyso-Gb3 level once the switch was made. The amount of substrate excreted in the urine was better with migalastat compared to the placebo. But in patients with end-stage estimated GFR or renal failure or declining renal function, migalastat did not reverse it. So there was no change in eGFR or measured eGFR from baseline to month 6. So once the damage is done, it did not bring it back up, which makes sense because damage sometimes is permanent. And at 24 months, as the open extension was going on, they noticed a significant decrease in the cardiac, in the left, they get hypertrophic cardiomyopathy, particularly if the left ventricle is affected, and the thickness of the left ventricular muscle, the left ventricular mass index was decreased. So the hypertrophic cardiomyopathy was helped. But there were no changes in the thickness of the posterior wall of the left ventricle. So some parts of the left ventricle were helped, some parts of the left ventricle did not see a significant change. And many of the patients saw a decrease in the GI symptoms. These probably are the classic patients. And here is a graph. The dashed line are those patients who were on placebo. This is the mean plasma lyso-Gb3, the biomarker that we measure, and this on the x-axis is the time. And the biomarker values remained unchanged when they were just on placebo. But when you introduce migalastat, there was a steep drop in biomarker values indicating response to therapy. whereas the blue line indicates those patients who from the get-go were randomized to migalastat, and they saw a decrease in the plasma lyso-Gb3 values that continued throughout the study. And similarly, the kidney interstitial capillary GL3 inclusions, those on placebo actually saw an increase, if you can call it that. But once you introduce migalastat, there was a significant fall, whereas those on migalastat had a nice drop and then continued onwards. This is another study which shows the same thing in left ventricular mass index. So this is after enzyme activity change after 1 year of therapy, and this is the relative decrease in mass index. So this is an independent study, different from the one that I showed above, which also showed reductions similar to the previous one. For some reason, it's not moving. There it is. So this paper I just found, it's probably the oldest follow-up, the longest follow-up between the trial phase and the open label phase and after approval of therapy of about 8.6 years or so. And these patients maintained renal function irrespective of treatment status. So this looked at patients who were ERT naive. You just got diagnosed with Fabry disease, you were never exposed to enzyme replacement therapy, and you were started on migalastat or on placebo, depending on which trial arm you entered. And then there were patients who were on enzyme replacement therapy already, but who were found to have a mutation that was amenable to migalastat, and then they were also randomized to migalastat versus placebo with just the ERT. And they followed them along, and we have an 8-year follow-up of these patients. And irrespective of whether you were ERT naive or ERT experienced, irrespective of your gender or your phenotype or how severe your disease was, the kidney function remained pretty stable on migalastat. And this is a huge thing because the gold standard, the ERT, enzyme replacement therapy, one of the whole approval and its treatment is based on its beneficial effects on the kidney in patients, particularly the type 1 patients. So this appears to be comparable. So I looked at what our Canadian friends thought of migalastat. And so this is the Canadian Fabry Disease Initiative registry of about nearly 500 patients with Fabry disease followed for about a 10-year period. And all known GLA mutations in the registry were evaluated using the assay that I just described. And in 466 patients, there were 814 different mutations, and 240, about 30% of the mutations seen were large mutations, deletions, duplications, frame shift, all those horrible mutations that we talked about, and these were categorized as non-responsive. They didn't even bother doing the assay. They said that they were non-responsive even without testing. But of the smaller missense mutations, 33% were responsive to migalastat, and 40% were not. And so this spread, so if you take the entire known Fabry mutation, about 30% are right away not migalastat responsive because they are these frame shift and severe mutations. And of the remaining 70, 30% are migalastat responsive and 40%, even though they are missense mutations, are not responsive. And this is very similar to data that individually we in our clinics see. And of course, if you have a large population of a particular cohort, so if you did this study in Taiwan, obviously the data is going to change because that particular mutation that is not migalastat responsive predominates in that cohort. So migalastat versus enzyme replacement therapy, it definitely has some advantages over ERT. It is oral, taken every other day, no infusion reactions, no need to go get an IV placed every 2 weeks or a central port or what have you, and all the problems associated with it. It is better bioavailable. It's a small molecule, so the tissue levels of the drug are much present for much longer than that enzyme replacement therapy, that protein that just lasts for a few hours, as I showed you in a previous slide, and also has a better tissue distribution. When they did skin biopsies and kidney biopsies and so on, they found that the GLA activity was much better on patients exposed to migalastat. And antibody formation and reduction in the efficacy of ERT as a result is not an issue with migalastat. The way it functions is very different. So we estimate that about 35 to 50%, depending on what population you treat with Fabry disease, have migalastat amenable mutations. And the drug got approved in these countries for children and adults and adolescents aged 16 years and older with a confirmed diagnosis of Fabry disease and an amenable mutation. And in the United States in 2018 for adults 18 years and older. So it's still not approved in the pediatric patients. So it's supplied as a blister pack. For those of you who are on migalastat, you know what I'm talking about. Since it's every other day, it's a special insurance approves it. The company does a lot of case management, and we work with them to make sure that the cost is not cheap. It is not cheap. It's about the same price as the ERT. So it's very expensive medication. So you take one capsule every other day, so 14 capsules a month, and the dose is pretty standard. Each capsule has 123 milligrams of migalastat, and it's the same in all eligible individuals, and it does not change based on body weight, unlike the ERT or the gender. And it's taken every other day, and when you advise patients not to take on consecutive days. So don't take it today and take it tomorrow because you know that you're going to be away on the next day and you're going to be missing the dose, because it doesn't work that way because of the reasons why I showed you. Do not crush, chew, or cut the capsules, swallow it as a whole. Take it on an empty stomach, and don't consume food 2 hours before or 2 hours after taking the migalastat to give it a 4-hour window. And you can take clear liquids like water, etc. But for the most part, try and keep it. And many of my patients look at me like, funny, like, do you really think I can do this? How am I going to do this? So I tell them most of us get up at least once in the middle of the night. So just take it. You're definitely about 3-4 hours after dinner, and you're 3-4 hours away from breakfast. Just keep it at your bedside and take it. And if you miss a dose entirely for the day, take the missed dose only if it is within 12 hours of the normal time. So if you normally took it at 4 a.m. in the morning and you forgot, take it if it is before 4 p.m. on the same day. But if you've missed that window, just forget about it and take it at the next planned dosing day at a time. 2 days later or the other day, according to the every other day dosing schedule. In special populations and its safety profile, we do not know the effects on pregnancy and on the developing fetus. So if a young woman who has a migalastat amenable mutation comes to clinic and has been on ERT and wants to switch, one of the questions we will ask is, what is your plan? Are you planning a pregnancy, etc.? And if they are, I will tell them to hold on till they've completed their family before making the switch. And so those are some of the decisions that are made in clinics. And there were 3 patients, according to the package insert, that were exposed to migalastat, pregnant patients that were exposed to migalastat, but no real adverse events were seen. However, 3 patients among so many is too small to estimate risks. So we are not advocating it in pregnant women, but if there is an inadvertent exposure or whatever, a pregnancy outcome survey has been launched by the manufacturer of the drug so that we can learn about what the effects are in the going forward. Similarly, distribution and the effects of migalastat in the breast milk and in lactating women are unknown. It is not approved in the pediatric population, and it was never really studied in individuals more than 65 years of age. And the drug is metabolized by the kidney. So those patients with Fabry disease who have poor renal function, where the eGFR is less than 30 ml, are not eligible. Even though they have an amenable mutation, they are not eligible to be on migalastat. And I recently had a patient during the pandemic. I was trying to see if I could do something, but unfortunately, his EGFR was so low that it was not possible. And it's a pretty safe drug. It doesn't interact with other drugs. And this is important for patients with Fabry disease who are on other medications. It does not really follow the path and decrease or increase metabolism of the other drugs that may adversely affect the management. No cancer or genetic changes due to the mutation, mutagenesis were observed. There is a line in the package insert that says there was a decrease in fertility of male rats who were given doses that were equivalent to the adult migalastat doses, adult human doses. But this was reversible. So as soon as the male rat stopped the migalastat, fertility returned. So some of the side effects that are reported, headache, and it's something like a sore throat, like as if you have the flu, and nasopharyngitis. Some patients have reported urinary tract infection, and then nausea, slight feeling feverish, fever, abdominal pain, back pain, cough, diarrhea, nosebleeds, etc., have been reported in these percentages. But there are no severe adverse events, death, and some of the other severe adverse events that are typically associated with the migalastat, and it appears to be pretty safe. And clinical monitoring. So here is a very nice paper that I found. So they had 2 mutations, N215S, that one that I showed you. And this is a patient was under treatment for about 13 months and showed a significant reduction of plasma lyso-Gb3, significant p-value is less. And there was another patient population that this clinician followed. Again, a missense mutation, but instead of N215S, this was a leucine at position 294 that changed to a serine. Now, if you look at the amenability table, this missense mutation was also found to be amenable to migalastat in the experiment when they did the amenability assay. However, when it was in the clinic, in the real world finding, when this patient with this mutation was given migalastat, 2 patients developed severe albuminuria. So the kidney function deteriorated. And when they did additional experiments, they found that indeed, when they used the CRISPR-Cas9 instead of the traditional experiment, they found that this mutation fared a lot better. The 215S fared a lot better than the L294S. So it is important for clinicians and for patients to say that just because you have an amenable mutation, don't stop seeing your physician. You have to return for lab tests, for biomarker surveillance, for cardiac surveillance, for renal surveillance, and what have you, because this is an ongoing process. So in summary, there are patients who respond to migalastat. It has been, since approval in 2018, the drug has demonstrated safety along with cardiovascular, renal, and patient-reported outcomes and disease biomarkers in patients in the real-world setting. And although a list of mutations is provided by the manufacturer, the treating clinician has to monitor the response. And in some studies, re-evaluation of mutations with poor biochemical response revealed no marked activity increase compared to. So I've had patients who came to me, one gentleman in particular, whose mutation was not amenable based on the amenability table that the manufacturer put out, but then another lab in the world did an amenability assay and found it to be marginally amenable or a little bit. Now, I told him that it is going to be very risky and I may not get an insurance approval to try him on migalastat because it is only approved and insurance will only cover if it is one of those amenable ones that are standard. So I just want to finish by saying there is a lot more to be done in Fabry disease because the enzyme replacement therapy that starts here definitely changed the course of the disease, but it's still not a cure. And we have agalsidase alpha that's approved outside the United States, agalsidase beta, which is approved here in our country, and then this drug, the long-acting PEG unigalsidase alpha, that is nearing completion of clinical trials. So these are enzyme replacement therapy. We have chaperone therapy. And then in the research world, we have gene therapy, of which Don and I are participants in various studies. And then if the substrate is accumulating in Fabry disease, can we just turn off the faucet and stop the substrate from accumulating at all? So this is substrate reduction therapy, again, remains investigational. But hopefully this is going to move forward and we will get better therapeutics in place for this condition. So that's my presentation, and
Perfect. Thank you so much. That was a very nice comprehensive overview. I'll see as people start putting in questions. I've got one here that is, we're looking at biomarkers, but in patients with Fabry, would you expect their enzyme to increase if you drew their blood? So could you test their blood to see if they're amenable?
That's a great question, and the answer is no. So these are specific assays, and testing the blood biomarker, the enzyme, as you would do for a diagnostic purpose, does not seem to affect. And that's not something that you can monitor carefully. And Don, if you have any experience on this, I'm happy for you to share it with us.
Sure. I would say that we've had several patients we've watched and just for fun sent off enzyme levels on, and we haven't seen that even patients with a minimal that we've seen a big jump or anything. It seems to be the same as baseline. Now, when we do that, we're usually looking at it in the white blood cells, and so we're not looking at serum. So I don't know if you looked at serum, if it would make a difference. But at this point, we've stopped sending off enzyme because it doesn't seem to be telling us anything new. Really, lyso. We seem to look at lyso a lot. That tends to be our biggest thing. And if it starts shooting up, we get worried.
Yeah. That biomarker that Don is talking about, I have a bunch of patients with that N215S. Now, if you look at the amount of Fabry enzyme that these patients N215S makes, it's pretty good. It's a hefty, I don't remember the number, say about 30% or 40% of the wild type with no treatment at all. Why these patients develop cardiomyopathy? And some of them had developed, I've had one gentleman who had a history of cardiomyopathy starting in his mid-20s. He was a college athlete. They told him, yes, you have a thickened heart, but it's probably because you're an athlete. And now in retrospect, he has Fabry disease. If you measure his biomarkers, they are below quantifiable limit, BQL. And his enzyme activity is reduced, and it is in the late onset Fabry range. And that mutation is amenable to migalastat. So very difficult to track and trend and monitor. And when they come in like that with a cardiomyopathy, again, the reduction in the LV mass index is not so sensitive that I can track it every 6 months, every year, or year to year. And then you add to it, we have a patient who had a pacemaker put in between starting migalastat, and the pacemaker interferes with the MRI reading. So the cardiologists are not able to clearly quantify the improvement, or any, if any, in the LV mass index. So there's a lot of practical difficulties that we face in the clinic. But for me, an ideal patient would be someone who comes in early enough, so that if there is a benefit to be had with one of these amenable mutations, I'm having it and I'm doing it before end organ damage has happened. And that goes to all the patients who are subclinical, not yet symptomatic, but are relatives or at-risk relatives of those with Fabry disease. They are the ones, I think, really, this may change the natural history for them as we move forward.
Great. I don't have any other questions in the comments that I see. Anybody else have any other questions they want to unmute and ask? All right. Thank you so much, Dr. Ganesh. And Jerry's going to now do some announcements. Do you want me to give the secret word first, Jerry?
Thank you very much, Dr. Ganesh. Thank you, Dawn. So we will move on to the announcements.
Want me to give the secret word while you're working on the slides?
Yes. Yeah.
All right, everybody, the secret word for the prize drawing for today is amenable. Give your best shot on spelling. Go ahead and just put amenable in the chat box. And our very able Brenda will give us who's winning once we have amenable in there.
Almost,
Nice job, everybody.
there's a bar right in the middle where I don't want it. Okay. Can you see that, Tom?
Yep, I can see it. You can put it in slideshow if you want. Yeah, there we go. Looks good.
All right, thank you. So each time we do a meeting, I put up some slides about to keep everyone posted in terms of what industry is doing. So let me go through these slides. So you can see the highlights for each industry partner. Each company has provided some resources on this slide that they would like everyone to know about it if you don't already. So you can see on Sanofi Genzyme and Amicus and Chiesi, they have particular websites that they'd like everyone to know about and know where you can access them. In AvroBio, Sangamo, 4DMT, and Freeline, they all have, they're all currently enrolling in clinical trials. And so there's information about how to get to each of those organizations if you're interested in those trials. And then back up to Idorsia, who is, and so the four are all gene therapy trials, AvroBio, Sangamo, 4DMT, and Freeline. Idorsia is a substrate reduction therapy that is no longer enrolling participants, but they're going through their study, and at some point will provide an application to the FDA for approval. So you can, this meeting is recorded, so you can go back and look at this slide and access the references at your convenience. Also, that went fast. We, on our website, I'm being very, I better not touch anything, very sensitive tonight. So on our website, if you look at the top menu bar, you scroll over to the company and clinic info tab. In this case, go down to pharma. If you select pharma, you'll see what's in the lower left. And each company has a grid square. And at the bottom of that grid square, there's a See More button. And if you select the See More button, then you can open up a series of, each company has various resources, more resources than were on the one slide, of either websites that you can get to, PDFs, infographics, clinical trial, www.clinicaltrials.gov site, so you can find more resources for each of the company. Likewise, if you go on the bottom and select support organizations, you'll see there's now 3 grid squares for our organization, the National Fabry Disease Foundation, and other support organizations, but the middle grid square in our 3 will have all the recordings from this meeting series. So right now there's a dozen links for the recordings for the first 12 that we've done, and the recording for this meeting will be up there in a couple of days. And also, you can access those recordings on the website registration website. Over to the far left, you'll see an archives recordings tab. You can also access the recordings from there. So once we've finished this meeting, we'll close this registration link, open up the next one, and put the recording over in the archives. And then the last slide I have is we still have calendars available that we're sending out. So if we try to send them out to people that are participating in the meetings, but if you don't have one yet, just email me and we'll get a calendar in the mail. And if you are participating in the conference on the September 11th and 12th, then the goodie box that you get with various resources and awareness materials and ribbons and wristbands and mouse pads and all that kind of stuff, you'll also get a calendar in that box. So if you haven't got one and you're participating in the conference, we will soon send you one. And like always, as I just mentioned, now we'll close the registration on this meeting. We'll open the registration on the next meeting. So in the next couple of days, look for the September 28th meeting, which is about eye involvement with Fabry disease. And I think that is all I have. So we're going to announce the winner of the prize drawing. So Brenda, do you have something for us?
She does. Do you want to say, Brenda? You want me to?
Go right ahead.
All right.
Yes.
Okay. The winner is Joseph.
Joseph. Okay. Well, I think I know who that is, but Joseph, just sure send me a chat and send me a chat box with your name. Is it Joseph C? C is in the letter C. I know it.
Yep, Joseph C. He's got his name in there. Joseph Carrick. C-A-R-I-K.
Well, I know who you are, but just put it in the chat box so that I'll know and we'll get you that gift certificate out. Well, thank you very much.
Jerry, do you want to comment on where people can sign up for the annual meeting that's happening on the 11th and 12th?
Yes, so we just sent an e-newsletter blast out to everyone on our subscription list. So we sent it out to 2,000 plus people. So if you didn't see the e-newsletter blast, then search for that in your spam folder. And also, if you're on our Facebook page, we put a notice on the Facebook page. Both of those have the registration link. And if you still don't find it anywhere, look on our website up in the top corner in the announcements section to find it there. And if you still don't find it, email me and I'll get you the link for the conference. But if you register for the conference by the 5th, we'll send you the box out. If you don't register by the 5th, you won't get the box in time because we're going to have all the boxes ready to ship on the 6th. So we look forward to seeing your registration. All right. Any other questions, comments?
Just want to say thank you, Dr. Ganesh, for that great talk. And I hope it helped everybody think about things. Oh, there's a calendar. Was that the calendar, Steve? Nicely done.
Yes. Very nice. All right.
Awesome.
We'll see you in the next meeting.
Thank
Bye,
you.
everybody. Thank you so much.
Bye-bye.
Bye.